You guys are gonna love it. We had an exceptional guest.
So I'm not seeing what's going on around me. Now I am seeing what I will accomplish as I rise above.
And remote learning and just trying to navigate all of this.
So if you got people who showing up to work every day and they don't trust you as a leader, what are you actually doing?
Identify people who have mental health challenges that may eventually result in violent activity. And we want to get to people before the police have to be called, not after.
I feel so touched, so empowered by her and what she's about.
Hello and welcome to the Chop It Up Podcast, the show that's unfiltered and unapologetic. Each episode will bring you closer to finding your purpose. And for our loyal listeners, a special surprise awaits you at the end. Be sure to listen all the way through. Now, here's your host, Carmisha Superville.
Welcome back to the Chop It Up Podcast. I am your host, Carmisha Superville. You guys, I am so excited and so honored to have this conversation with someone that I absolutely admire. And let me just say, this is very hard to book. It's very hard to book. But of course, I am so grateful and honored that he obliged and he's spending his time with us because he's super busy, you guys. Guys, I can't even imagine having him on our platform. This is a guest I really wanted to speak to, especially because so many of our listeners are female. Maybe 80% of you guys are female. So ladies, this is for you and our men, our brothers, our uncles, our husbands. This is also so that you can learn and see the signs. Tonight, we will be speaking with Dr. Michael Lewis. He is the Vice Chief of Gynecology at New York Methodist Hospital and Director of Minimally Invasive Gynecologic Surgery. Did I say that right?
Perfect.
Awesome. Dr. Lewis,
Good job.
welcome to Talk Up. How are you? Thank you.
Great. Thank you for inviting me. It's a pleasure to be here. And even though you said most of the listeners are female, again, it's what we're going to be talking about also, like it affects the families. So it affects everybody in the family, affects men and women. And so I'm glad to be part of this conversation.
Yes, absolutely. You're so right. So thank you for being a part of this conversation. Before we get to the heavy stuff, let's talk a little bit about your upbringing. So where did you go to school? I mean, I know, but tell the listeners, where did you go to school? And Dr. Lewis, did you always want to be a surgeon? How did you get from, college graduate to becoming a surgeon and the vice chief vice of gynecology? Give us a little, journey.
Okay. I won't bore the listeners too much. It was a short synopsis of it. So number one, I grew up actually in Canada. I grew up in Montreal. And, I think from a young age, I always had this interest in helping others, helping people. I would generally volunteer to be what was like an EMT assistant. Then I eventually ended up being an EMT and sort of wanted to always be taking part in terms of anything that was medically oriented. I ended up, going to college, did my undergrad at McGill University in Canada, and then ended up going to medical school in the Caribbean. So I went to medical school at St. George's University in Grenada. And then during that actual process, our third and fourth year rotations I had the capability of actually coming to New York. And my mom was actually born in New York. So I said, oh, we're better placed than to come to Brooklyn. So that's where I came here in 2003, and I did my rotations even at Methodist Hospital. I then stayed for residency training there in obstetrics and gynecology. Finished my obstetrics training, which was, med school is 4 years, residency training is 4 years. Then I wanted to do my fellowship, which, again, a subspecialty because I love doing surgery so much. And it was a 1-year fellowship at Stanford in California. We did that for a year. And then I ended up coming back. I was like, sort of, once I had left there was no real program for minimally invasive surgery at Methodist. And I proposed to them. I think we should start a program when I get back. And that's what I did. And I was invited back, and I've been an attending at Methodist since 2010. And then I've worn many different hats. I did a lot of residency training. I was a program director. I ended up being, promoted to vice chief. This was about 2 years ago. And it's been quite a voyage, but it's been, over 20 years that I've been at this hospital. I think I'm, well rooted into this place. And, I don't think I would live anywhere else in the world but Brooklyn, New York.
Yeah. Oh my gosh. But Dr. Lewis, you look so young. So you said you've been on this journey for 20 years?
Yeah, I mean, even a little bit more, I guess. I mean, if you included all the training and everything, yeah, it's been a long time. I look young. Maybe it's the water here,
Yeah.
but
Wow. So let me ask you, how was your Caribbean experience? Like, I know you spoke a little bit earlier. Talk a little bit about that culture and what was the difference when you came to New York to study and so forth?
well,
Studying in
one
the
thing
Caribbean.
is, yeah. Well, one thing is I didn't realize how many people from Grenada live here. And so many of my patients are Grenadian, and we talk about having callaloo soup all the time and where I can get some. But it was, I think maybe it was a culture shock of being in the Caribbean, living there for the first time ever. But it was definitely the way, complete opposite of New York. New York is fast paced there. I think it's probably everything. You take your time, go relax, come back in an hour. We'll be with. I mean, it was probably one of the best experiences was going there. I actually lived there for 2 years. I lived in Grenada, and I also lived in St. Vincent for a semester there. So it was quite the experience of being in the Caribbean. Did a lot of sailing and swimming, scuba diving, definitely, and had some of the best, curry chicken, and so it was fantastic.
Yeah, that's amazing. I love that. So is it fair to say that you're very cultured?
Well, absolutely, absolutely.
That's good. I love that. So, Dr. Lewis, okay, so you have a 20 plus year journey in this medical field. Let me ask you, what, first of all, what keeps you motivated? Because certainly sometimes you get so bored, in sometimes in your career, but of course, if you have a passion and so forth. But what keeps you motivated? What keeps you still, excited when you see a new patient or when you see a patient
Yeah.
comes into the office? Like what keeps that grit going?
Well, I think in my specialty, having specifically doing the surgery, you're getting that instant gratification back as a surgeon when like you operate on a patient who's either got pain or some fibroids or a cyst, and you remove it and you see that instant result on the patient in terms of an improvement of their quality of life. I mean, that by far is what keeps me wanting to go back and more and help more patients. It's that wanting to help people, right? It's that wanting to make people feel better. And I always had that as like a young age, even though, yes, I wasn't operating, but now it is, we don't realize it's such a privilege as a doctor to take care of a patient, and for that patient to allow us to put them under anesthesia, to literally cut them open sometimes, even though we do everything minimally invasive. It's that's what keeps me going. It's amazing, and to share that experience with the patients and their family, it's something that brings me back every time to just help more and more patients. And I wish I could help more. That's the one thing is that you come to patients with pain, you want to help them out right away. You don't want to tell them that there's several weeks before we got to wait, or we got to schedule something, sometimes months. And even so, there's also sometimes some patients that you try to help and you can't help as much as you would want to. And so you have that attachment to really do whatever you can, whether it's my services, and we use like a multidisciplinary approach. We use a lot of other doctors and physical therapists, physiatrists, nutritionists, all to help these patients to help improve their quality of life. And then a lot of patients who also want to build families as well. So it's improving their fertility, their quality of life, both of those.
I love that. I love that. And I can attest to that. I know the first time when I met you, I just felt so comfortable, and we're going to talk a little bit about that later on in the conversation, but I just felt so comfortable. I felt like you listened, and I think that's so remarkable. But Dr. Lewis, I wanted to ask you, because it is only you, and certainly you work with your colleagues and so forth, but were you ever interested in maybe teaching so that you can replicate everything that you are into the next generation of medical professionals?
Well, it's actually something I do teach every day. A lot of my patients don't realize that. So, we have a residency program. What does that mean? So when I was back in, this was 2005, when I started my residency training at Methodist Hospital, that's when you finish your medical school training, you're about to start, now you're going to train in something specifically. So that was obstetrics and gynecology. So as a resident, and I have now residents that work with me in the operating rooms, and it's 4 years again. So it could be their first year, second, third, or fourth. And I have the opportunity for them to be with us in the operating room, and we're guiding each other. I'm helping them, they're helping me in terms of, having a great outcome in terms of surgery. And it is a constant teaching experience for them. We teach outside of the operating room and lectures. We do simulation studies. We do simulations on both robotic, laparoscopic, open cases. We do, we do pig labs as well that we've done as well. So there is plenty of teaching that most patients have no idea what happens in the background. All of our residents are in the hospital, starting rounding at like 5:36 in the morning. They round on the patients, then we have several lectures, and then we're off to the operating room. So, and then the day doesn't end there. They have certain days that are protected. So I give lectures. I give what are called ground round lectures, like big talks to our residents. And then the other thing, the opportunities that we have as well, is that there are, meetings that are both, regional within New York City, but also national and international, that we have the opportunity to not only as a doctor, you're continually learning. I'm always going to conferences, regionally or nationally, sometimes internationally, to just know what's the latest, what are the newest updates, newest outcomes. And I'm sometimes able to bring some of my residents. Sometimes we present our research at those meetings as well. So it's something, like I said, it's a continuum of teaching that we do every day. And then that also is what doesn't allow us to be bored, because the fact that we always have somebody curious, one of my residents curious, asking questions all the time. And it keeps us young, of course, but this is how we're preparing our next generation.
Yeah, I love that. You said it so well. Is it similar? So, paint a picture for our young listeners. Is it similar to Grey's Anatomy? Is it similar to that?
I mean, essentially, yes. I mean, I watched. Look, they dramatize everything, right? But they do a pretty good job, making some comparison. Yes, of course, there's always drama that happens with the residents and stuff like that. But it's a fair amount way of saying that, yes, there is teaching that goes on. People get into fights. But this is generally a well-oiled machine in terms of how well we are pumping out really great surgeons every single year. I mean, our graduating class, again, they're going to be graduating next month. Is the graduation party. 4 new residents that are coming out. They're going to be coming out. So it's really good.
Yeah,
Going to grab some water.
Right, of course. No, this is amazing. I'm so happy I'm speaking to you, getting a little behind the scenes madness. Yeah. Let's talk a little bit about inspiration, because you can't do this work without having some type of inspiration. Who are your inspirations, whether in the industry or outside? Who are some of your inspirations?
Well, I think, one of my specific field was there's a lot of, when I did my rotations as a student, it happened to be that one area where every attending, this is what I am now, but everyone loved doing what they were doing. They enjoyed coming to work. And I saw that, when I wanted to figure out with my residency training what I thought what I would be best at, or most comfortable at, I wanted to be in an environment where everyone was generally happy, and also when initially doing my rotations and we're doing deliveries and obstetrics, that's very gratifying. We obviously did see a lot of horrible things, and we see a lot of trauma, but mostly everyone was in a happy mood, positive experience. So that was one thing that just got me there. But then when I finished my residency training and I wanted to do specifically minimally invasive surgery, I had the opportunity of working with the inventor or the creator of video laparoscopy. His name was Cameron Najat, Dr. Cameron Najat. He was the one, my mentor out in California. And he introduced me more also to endometriosis. I mean, I saw it very briefly during residency training. It wasn't really taught as well in terms of how to properly treat it, excise it. And I would say 95% of the cases that we did during my fellowship training was all endometriosis. It was like a new window had been opened, and I really saw how he was able to, you know, make a huge impact on not only the patients but their families, and realizing how much it touches. And I thought, you know what? There's also nobody treating endometriosis specifically back in Brooklyn that I can remember at our hospital. You know, there's definitely a lot of other surgeons in New York City today, but at my hospital particularly, there wasn't really much that I saw. So he was really that helped drive me to help continue and develop this little niche of treating patients for endo, and sort of help teach all my peers, my colleagues, but also teaching the residents. And it was also only I gotten a sneak peek of endo during my residency training. And this is through another doctor, Dr. Sechkin, Tamara Sechkin, who's actually the president of the Endometriosis Foundation of America. And so it was like through him who gave me that eye-opening of like what endo is, but then learning and the teaching with my fellowship with Dr. Najat. And I still keep in touch with him to this day. I mean, we share stories. We've done research, you know, during our fellowship training, and it's sort of like this family. And there's not that many, you know, surgeons specifically across the country who treat endo, you know, and, you know, it affects 1 in 10 women. So there's definitely a need for a lot more trained surgeons, you know, and that's what we're trying to accomplish.
I'm so happy you spoke about that, because that is exactly where this conversation is going to go as we segue into the oh my God, I'm not so on tongue tied. But you know, to your specification, to what you stated, what are the causes, and how has it affected mostly your African American female patients? Like, what are the causes, and what could we do? What should we be looking? What are the signs we should be looking when it comes to intermediate system?
Okay, so well, number one, it affects 1 in 10 women, and that I mean 1 in any women. Doesn't not specifically one race or the other. And the most common thing, and the one thing that you should realize, and this goes to all the listeners, is that a painful period is not normal. That's the most important thing to remember. Painful period is not normal. Patients who miss school because of their periods, patients who miss work because of their periods and have to stay home, you know, this is not normal. Having nausea, vomiting, having horrible pain when they have to have a bowel movement, or pain when they urinate, you know, during the period. These are the telltale signs. And even patients who have pain with sex, with intercourse, also not normal. And the thing that is shocking is that patients with endometriosis, usually from the time of their symptoms, where it's, you know, a little bit more noticeable until diagnosis, is about 7 to 10 years, which is, you know, when you hear that statistic, you know, you think, how is that even possible? And again, like most symptoms will start for these patients a lot younger. It may start in their teenage years or college years, and they usually are not seeing a gynecologist. They're usually seeing their pediatrician, or they may be seeing a primary care doctor, or then they're referred to a gastroenterologist. They sort of bounce around between different doctors who then give them a wishy-washy opinion. You know, most imaging studies that they do, CAT scan, ultrasound, may initially be negative. So they'll look at an imaging and they'll say, oh, it's negative, there's nothing wrong with you. But they continue to have worsening pain. And this is a progressive disease. So it is a chronic progressive disease. As you go further and further on with more of your periods, more pain, it's doing more damage, and it can affect your future fertility, It can affect, obviously, your quality of life, the way that you're able to advance in your career, able to complete, your college degree or your master's, anything. I mean, so, and then, like I mentioned before, it affects everybody involved with you. So it affects, your partner, it affects your family because you're not going to events, you're not able to participate. So it has a huge impact, on our, pre-menarche, even like in terms of patients who are just about to get into having their periods. Once if they start having painful periods and it's just continuance, it's not normal, like I said, and they need to see a GYN doctor who, if they don't specialize in endometriosis, at least knows and understands, well, these are the, most common symptoms, and I should be referring them to someone who can take care of them. Because you don't have to have surgery right away. That's what some people say, like, okay, you need to have surgery right away if you have endometriosis. Obviously, every scenario is a little bit different, but at least you can start treating them clinically just based on their history. And that's usually involved, whether it's a birth control or even pain medications initially. But if they don't get better, that's when you definitely need to be seeing a GYN surgeon, And it always depends on the age, because sometimes patients may also have zero pain. They may have no pain whatsoever, but they're in their 20s or they're in their 30s and they're trying to get pregnant and they're not getting pregnant. 50% of the time when patients are trying to get pregnant, the reason is endometriosis. So what's scary is that you can have also endometriosis. Now, you mentioned pain. You can have no pain and still have endometriosis as well.
I like how you said that. So okay, you spoke about the signs, and thank you so much for elaborating on that. For our listeners who don't know exactly what we're talking about, break it down in layman's terms. What is it?
Endo.
Like,
So
yeah.
endometriosis. So again, you have several layers of the uterus, okay? The endometrium, which is that inner lining of the uterus, those cells that you slough off with your period every single month. Like when you see blood, there's actually cells of the lining of the endometrium that will come off as well. And they regenerate every month, because you didn't get pregnant. The whole cycle is that lining gets thicker. It's thinking you ovulate. It thinks you're going to get pregnant. You don't get pregnant. And then it's like, okay, well, then we're going to slough off and we're going to regenerate again. It's those cells that for some reason, and there's several theories in terms of how it happens, but those cells end up inside the pelvis. They end up on the fallopian tubes, on the ovaries, on the what's called peritoneum. That's like the inner lining of your pelvis, and that could land on your appendix, on your intestines, on your bladder. And usually where those implants are is where you usually get your symptoms. You can even have endometriosis in the lung. You can have it up, I mean, they've literally had the diagnosis of endometriosis pretty much everywhere in your body. But again, most commonly, it's in the pelvis. But we have seen extreme cases where, again, like you can have it in the thorax or the lungs, up in the upper abdomen. But most 90% and 95% of the time, it starts in the pelvis.
Wow. In the lungs? Wow. Have you treated any patients with that?
Yeah, I mean, we've had patients, again, who've had endometriosis in the pelvis, but then also had symptoms where, monthly they would either have pain in their chest, difficulty breathing, or they would cough up blood. And so it is very rare to see thoracic endometriosis, but it's also possible. You have more commonly before that would have bowel endometriosis, so they may have blood in their stool or have really, really painful bowel movements, or pain with intercourse, which may be a sign that it may involve the intestines.
Wow, it's amazing. So, Dr. Lewis, many years ago, I think prior to the pandemic, I started experience, and of course, in full transparency, as I'm sharing with my listeners, because that's the only way we learn and we grow is by sharing our own experiences. So prior to the pandemic, I went to my gynecologist, and Dr. Lewis, I don't like to switch out doctors. I am very loyal.
Of course.
Yeah, to a fault. Sometimes to a fault. Like I'm so loyal. I just don't like the headache. If something works for me, it works. Nonetheless, I had visited my gynecologist, and I expressed to her at the time. I expressed that, again, I didn't know any of what we are talking about right now. So I was like totally virgin. Like I literally didn't know. All I knew is that I was starting to have discomfort. I was starting to experience a lot of discomfort during my menstruation, leading up to and even after. And then what I noticed is that my menstruation will last longer than the 7 days or than the 5 days, right? Sometimes I'm going into the second week. Yes, Dr. Lewis, it was that bad. And so I found myself having to take pain medication just to get me along. Don't know what was going on with my body, didn't even overthink it. I went to the gynecologist and I said to her that I've been experiencing these pains and I really don't know what it is. I cannot forget what she said to me in that moment as I'm expressing to her that I'm just experiencing this pain. She said to me, Dr. Lewis, pain is relative. This is what my gynecologist for years, by the way, that I've been, going to her. She said pain is relative. I didn't think anything of it. I left. I wasn't mad or anything like that. I asked her if there's something I should be doing. She said, well, you're already taking the pain medication. And if you're only taking it when you're on your menstruation, then I would, just suggest that you continue. I said, okay, continue
Right.
taking the pain medication. The beautiful thing about life is that we have to communicate. We have to speak to our folks and speak to friends and family. So I was occasionally, just casually, speaking to a friend, and I was expressing to her some of the discomfort, and she said, "That's not normal," and she suggested you.
Yeah, definitely not normal. And she's very, very smart friend.
Yes. And I can never forget walking into your office. You sat me down. You saw the disbelief on my face. I was very much emotional. I was like, what is this white man telling me? Like,
Of course. And we're getting to the meteor stuff now. So we're going to talk about fibroids.
so you sat me down and you were so eloquent and so empathetic and everything I think patients look for in doctors. So let's talk about that. Let's talk about pain is relative, and let's talk about the issue of fibroids. Let's talk about so many women that are dealing with this in silence, so many young girls. As you said, it's a chronic and it's a progressive, this is a disease
Yeah, it's a
or
disease.
disease. Yeah, it's not a
Yeah.
disorder.
No, it's a disease.
It's a
Yeah.
disease.
So there's, let's not forget. So we're talking about endometriosis, which affects, 1 in 10 women. And that's that chronic progressive disease where those cells of the endometrium implant themselves in the pelvis. But then we talk about fibroids. Fibroids are smooth muscle tumors that are benign, generally benign, 99.9% of them, but they grow within the muscle of the uterus. And they can be, they affect actually 70% of women. And these affect more Black women. So, the majority of my patients, however, though, they can still affect any race, but I see them much more in Black women and much bigger, more numerous and the bigger. But there's two things that are going on. Generally, endometriosis is what causes pain. The fibroids usually don't cause pain unless they get so big that they start to outgrow their blood supply and they start to die. Okay. So, but at the same time, it depends on where your fibroid is. That fibroid tumor can be on the inside part of your cavity, that same area of the endometrium, or it could be in the muscle, or it could be on sort of growing onto the outside. Now, if it's growing on the inside, that inside endometrium, it's going to cause a lot of almost pain because your uterus every single month is contracting, trying to get it out. And your periods are going to be super heavy and they're going to last forever. They're going to last greater than 7 days. You're going to have clots the size of what initially you may see quarters. And then it's like, I had a clot the size of my fist come out. So you'll have tons of clots that'll occur with them. these are the ones that are sort of in the cavity or within the muscle. The ones that are on the outside, think of it like as Mickey Mouse ears. Those are the ones that are going to be causing a lot of pelvic pressure. They're going to be pushing on your stomach, like you got to go to the bathroom all the time. You have urinary frequency. They may feel or look as if like you're completely bloated. And you may also have a lot of back pain with it as well, or pressure, because just from the bulk symptoms of it. So generally the fibroids are causing either heavy periods or the pelvic pressure and bloating, or both. And then if you add fibroids, which a lot of women, about like 30% of the time, you may have patients with fibroids who also may have endometriosis. You can have both of these symptoms, all these symptoms going on, which makes it, a difficult scenario, but still one that's able to manage. And you can do everything in one surgery where you're treating and excising endometriosis and you're excising the fibroids as well.
Wow. I didn't even see when you stopped.
Yeah, it's a lot.
I was so engaged with everything that you're saying. Oh
Yeah,
my
but
goodness.
but the thing is that, like, the problem is, again, like what you said, like loyalty to your doctor. And it's true. We have patients who come see me, they've seen their doctor for years, and like, my doctor never told me anything was wrong, or they did imaging and never said anything was so serious, but that's the problem. Your doctor didn't either realize it, and it's shocking that there's gynecologists who are trained in recognizing, when to refer, but they just don't. And they feel like, oh, because pain is also, like how you were saying, relative. Yes, it's relative, but it's not normal. Pain is not normal. The amount of pain could be different from every single patient, but it's still not normal to have, and you want to address that. And you need to have a doctor that's going to sit there and is going to say, instead of just like going through, like you come for an annual checkup and you just run through everything and you get out of there, your doctor should ask you, like, tell me about your periods, open-ended questions, so you can start asking or answering, not them just asking specific things and you say yes, no, and then you're out of there. They really have to have the time. And that's the problem, is that most doctors today are jam-packed with their schedules. They don't have the time to sit and listen to the patients. And unless the patient is coming in with a specific symptom or referral for this, it ends up getting pushed to the back, not really listened to, and then you're back at square one and you got to find somebody else.
Yeah, you're absolutely right. And that leads me into asking the question, what are the right questions or the correct questions that patients can ask their gynecologist? What are some questions that they can go in with and ask?
Right. So I think, number one, in terms of saying that my period is painful and this is not normal, what can this be? And stating like all those symptoms. If you have pain with your period, pain with bowel movements, pain with urinating, like that's not normal. Okay. Then in regards to, like, for fibroids, I'm having such heavier periods than normal. My periods are coming so heavy and lasting so long. I feel weak. I feel tired, because the more you bleed, your hemoglobin, that's your think about your blood volume is decreasing every single month, lower and lower in that tank. And eventually you're going to get short of breath. You're going to get fatigued. I have patients, who walk around severely anemic because they've been used to this for so many years, not knowing. You're like, why am I so tired all the time? It's because your hemoglobin is so low. You're anemic, and you need to have a certain hemoglobin to function. You need to have a certain blood volume pumping through your entire body, through all your organs, so that you don't feel short of breath or tired when you're exercising, when you're even just walking to work, when you're playing with your family, picking up your kid. You really need to address this to your doctor and say, there is something wrong, I need help. And then telling them, if you don't operate, or if you don't know how to manage it, can you at least refer me to somebody that can, and say, like, I have nothing against you, but like, for maybe because that's the thing, a lot of OB-GYNs today, they either focus on obstetrics or office procedures. They may not operate. GYN surgery, there's not as much surgeries these days as it was in the past. And so it's harder, but at least if they can have a right referral system, the right place to send their patients, and which we do. We have a lot of outside referring doctors that we say, look, we know you're busy. We know you're busy either in an obstetrics practice or your office practice. Send us your patients. We'll take care of them. And then we send them right back. So it's something that we're trying also to get more into the community, to get to other doctors and saying like, look, painful periods, not normal. Heavy periods are not normal. Let's do imaging. Let's ask more questions, investigate, and see, depending on every patient, because every patient's needs are different depending on their age, how we can help them improve their quality of life or impact in terms of have an impact on fertility.
Yeah, definitely. I love that. Absolutely. And we need to definitely amplify that message as well into the community, especially
Absolutely.
with the
Yeah.
communities of color. Okay, so Dr. Lewis, as we close off, and thank you so much for elaborating, let's talk a little bit, and we have spoke offline about this particular case. Jessica Patteray, she was a lovely, beautiful 36-year-old. She was a mother, she was a wife, and she was a social media influencer. Jessica had been experiencing pain. When I read her story, she had been experiencing quite excruciating pain over the course of 2 years, I believe, in and out of hospitals, in and out of emergency wards, and all that. I believe recently Jessica passed away. She died from a misdiagnosis. They diagnosed her and stated that she had fibroids, when in fact she had stage 3 cervical cancer. Dr. Lewis, when I read that story, immediately I reached out to you. I was like, did you screen me for cervical cancer? I just want to
Yeah.
know. And I would just say in this moment, rest in peace, Jessica. But that story really touched me. I want to ask you, in your professional experience, what happened? What went wrong?
So again, this comes back to preventative screening, your routine GYN visits. Again, I don't know all the background, I can make some suspicion, but also I had a story very similar to this, probably about 15 years ago, 14 years ago. Similar, person that was a similar age. So what is a pap test? Okay, what is a pap smear? The pap smear is it's a screening test, and we're checking for abnormalities in the cells on your cervix. You have the cervix, which think of it as the entrance to your uterus. We're brushing off those cells and we're looking under a microscope and we're seeing, are those cells normal? Yes or no? And we also check, depending on your age, if you're over age 30, we're checking for the HPV virus, the human papillomavirus. This is a screening test that all women over age 21 should be getting. And the recommendations for the frequency of this test has changed. Before it was, after age 21 every year. Then it's been changed every 3 years, and 3 to 5 years. It really depends on how it's been. But the good thing about that pap test, it's a screening test. So if it comes back positive, then the next thing, meaning abnormal, the next thing you do is something called a colposcopy, where we're sort of taking a closer look at the cervix, say, okay, there's something abnormal, what's wrong? We take a biopsy. Human papillomavirus is tied to cervical cancer, meaning that it is associated with increased risk of developing it. If left unchecked for a long period of time, this will not overnight, and this is something that doesn't happen quickly. Which is scary, is that it can slowly turn into cervical cancer. Now, what was the screening test for this young woman? Did they do it properly? Because also, if you don't do a proper screening test, there's no use of even doing it. So, that's the one thing is like, did she ever get those screening tests? And if so, how often? When was the last time she did it? There are very, very rare instances where you can have cervical cancer growing further in the cervix where you don't see it. And that's the case of almost the exact same situation of a patient that we had treated years prior, where, again, she was actually referred to me for fibroids. We thought it was actually going to be a straightforward laparoscopic removal of a fibroid, but we go in and there's a mass in the specific area where this fibroid was, but it was actually cervical cancer. And it was extensive cervical cancer that was never picked up on her pap test, on her screening test. But she had symptoms of pain. And so these things, like, again, it shouldn't be missed. We have for our young women, for our kids that start, we actually get the HPV vaccine that starts for both men and women, or the boys and girls at age 9, between 9 and 11, which is generally recommended. They usually get this vaccine, and this will decrease the risk of having, HPV in the future. But still, for women today, older, who never had the vaccine, this is still something that really should not happen if they have access to preventative care medicine and able to get their pap test. So again, I urge everyone to do their routine screening, make sure that they're asking for the pap test. And even when they do get their pap test, they see the results so that they know that it was done at the appropriate, it was done appropriately, because you can have an evaluation and say whether it was satisfactory or not, and to make sure that if there was normal cells or abnormal cells, because if it's abnormal, then you need to do a colposcopy, which is a more definitive test to say, like, okay, is it really abnormal? Yes or no? And a lot of times we do a biopsy. Yeah.
A lot. Were you able to save that patient? I know obviously she had cervical cancer, but was she able to?
No, so that was a case where it was very advanced when it was found, and same thing. She had like several children, and she didn't survive. But this is something where, cervical cancer, the good thing about it is that we have a screening test. Breast cancer, the good thing is that we have mammograms, we have a screening test. Colon cancer, we have the screening test. People need to do the recommended screening regimen. Obviously, there's always outsiders. There's always these rare cases that things should have, like, how can this happen? And we're seeing younger and younger men and women with cancers that we've never seen before. And so it's really important to speak to your doctor, make sure you get the screening tests, and do it on a routine basis, not once and think you're done. It's having to have it at the regular routine requirement in terms of getting your pap test, mammogram, colonoscopy. Yeah.
It's funny you said that, and thank you so much for highlighting that. I was watching the news recently. This young lady, I believe she's 24, 25, has cancer. What's happening, Dr. Lewis, in terms that you even said it, that you're seeing younger and younger patients getting diagnosed with cancer? Is it the food? Is it the environment?
I think it is multifactorial. It's part in terms of what we put into our body. Some, has to do also where we live, what we're ingesting, our genetics as well. Some people are more predisposed to develop cancer than others, but it's something where also, if you have a strong family history of cancer, there is so much more new advances in genetic testing to see whether or not you're a carrier, to see whether or not you're high risk of getting certain diseases that it's offered today, or, and it's also, most of them are all covered by your insurance, and if it's not, even out-of-pocket expenses is so low. But really, this is also one of the parts when you're doing a routine annual checkup with my patients is we go over family history. Who in your family has cancer? Which relative? How many? Like, we go into detail. And then if you that's sort of me screening to say, okay, do you fit the criteria for needing to have one of my geneticists talk to you and get specific genetic testing? So some people do. And this is, again, like, we're going to ask certain questions. If you have a strong family history of cancer, you may want to get genetic testing.
Got it. I hope our listeners are taking notes, because I think this is one of our most imperative episodes. All right. So Dr. Lewis, as we close off here, thank you so much again. I wanted to ask you about what's next. What's next for Michael Lewis? I know you're a dad, I know you're a husband, and of course you have a robust career. How do you juggle it all? Are you writing a book next? What's going on?
You know what? I think, the fact that having little projects all the time is very important. You mentioned a book. Yes, I've always said I want to write a book, but again, having the time to, the memoirs, of what we do would be great. But it's, I think it's really in terms of getting out more into our community and speaking more about endometriosis, fibroids. I think, we have to teach more. We have to educate everybody, and it starts from, the nurses in the schools, the parents, everybody in the family's got to know, like, okay, this is not right. This is not normal that my sister has such painful periods and she's missing school or she stays home, or it's not normal that my wife is missing this birthday party or this event or this concert because she's worried that she's going to bleed through her clothes. So I think more for now, I'm focusing more on like patient outreach and really working in the community. I know I can actually, I'll probably send you the details. I know our hospital is there's a health fair coming up in Brooklyn. I know it's June 1st. I got to get at the details so I can send it to you. And I know some of us are going to be there from our department and also from our hospital. So I can find you some details, but definitely, I mean, it's more in terms of outreach. We gotta speak more to Brooklyn, and definitely because our community, again, we have a bigger population in Manhattan, and we definitely don't have enough providers here, that are sort of helping or reaching out to our patients. So we got to make some noise and really get our patients come from screening, come in for their checkups, and also, get treated for your both fibroids and endometriosis.
Absolutely. Really quick, what studies should folks be looking into or reading? What studies are coming out there that we should probably focus on in terms of everything we just discussed?
That's a very, very hard question because, like one of the hardest things is when patients come in and they read this on Google, or I mean, it's hard to separate what is, what's, yeah, exactly. Not facts from fiction, but just knowing like what's real, what's true. We're seeing all these, social media platforms, especially TikTok, where, yeah, there's a lot of good doctors out there. They're actually providing short, quick videos about certain medical conditions, things you should do in your diet or whatnot. But you know what? I don't want to say anything specifically what you should read or should not. My main thing is you should speak up. If you have a problem, you speak to your doctor, and if your doctor won't listen, you go somewhere else. You really need to speak up. You have to voice yourself as a patient to say, like, look, this is not normal, and someone can help you. You just got to find the right person.
Yeah, I agree. I agree. Dr. Michael Lewis, Vice Chief of Gynecology at New York Methodist Hospital and Director of Minimally Invasive Gynecology Surgery. It's been an honor. It's been a pleasure having you on this podcast. Thank you so much for availing yourself to this amazing and most impactful conversation. You are doing God's work. You really are. You are doing God's work. And so with that, I will continue to pray for you and pray for your hands and your team to continue to bless and anoint your patients. Thank you so much for joining us.
Thank you so much for inviting me. Coming back, I'd come back anytime. And again, it's been a pleasure, and I wish you well.
Thank you so much. Thank you. All right, you guys, we are at the end. As you guys already know, make sure you like, subscribe, and what? Share this episode. Bye, you guys.